When you think about the foundation of a building, um, you usually just assume it's the most resilient part of the whole structure,
Right,
like
absolutely.
the concrete, the rebar, that invisible layer that basically holds the entire house up against gravity.
Mm,
If you notice a crack in the drywall upstairs, your first instinct isn't to think, that the foundation is dissolving. You just patch the drywall.
exactly. You treat the surface level symptom and you're completely missing the structural failure happening right beneath your feet.
Yeah, but if you ignore a dissolving foundation for long enough, eventually the doors stop closing, the floors warp, and the house just becomes totally
It
unlivable.
slopses, yeah.
Right. And today, for you listening, we are looking at a medical condition that does exactly this to the human body.
It really does.
We're pulling from this really fascinating stack of clinical guidelines, histopathology reviews, and dermatology research from places like NCBI, Stat Pearls, and DermNet.
Some really robust sources.
Yeah, and we're using them to unpack a chronic, deeply misunderstood inflammatory skin condition called lichen sclerosus, or LS.
And for our mission today, we are going to zoom way, way in on a highly specific microscopic battleground.
A foundation.
Exactly, a structural foundation layer in the skin called the basement membrane zone. We really want to understand how the thickening of this microscopic layer dictates what is an incredibly painful clinical reality for these patients.
And why spotting that tiny cellular change can literally be the key to saving a patient's entire quality of life, right?
It's everything. Spotting it is everything.
Okay, let's unpack this. Before we, pull out the microscope and look at the basement membrane itself, we have to establish the macroscopic stakes.
The surface level.
Right. When someone actually has this disease, what are they experiencing day to day? Looking at these clinical guidelines, lichen sclerosus is categorized as a progressive inflammatory dermatosis,
That's
and it predominantly attacks the anogenital region, so the vulva in women and the perianal area. Though I was surprised to see the data notes that in about 15 to 20% of cases, it shows up on extragenital skin too.
Yeah, places like the neck, the shoulders, or even under the breasts.
Wow.
And the demographics of who it targets are really striking. There's this distinct bimodal peak in women.
Meaning it hits two specific age groups.
Exactly. It frequently strikes prepubertal girls, drops off, and then peaks again significantly in postmenopausal women. But, and this is a huge but, it is crucial to note this is not exclusively a condition affecting women.
Men get it too, right?
Men develop it as well, particularly uncircumcised men. Historically, in male patients, it's been referred to by a rather intense medical term, balanitis xerotica obliterans.
Balanitis xerotica obliterans,
Oh.
which literally translates to a dry, obliterating inflammation.
It's a heavy term.
That alone paints a bleak picture of the severity. So, the hallmark symptom across all demographics is intractable pruritus. And reading the clinical descriptions, itching just feels like a wholly inadequate word here.
Oh, itching doesn't even begin to cover it. We're talking about a systemic, relentless nerve firing that drives patients to the brink.
I read it frequently disrupts sleep to the point of chronic exhaustion.
Yes, leading to severe psychological distress. It is an all-consuming sensation.
God, that sounds awful.
And along with that pruritus, patients experience severe burning, dyspareunia, which is severe, tearing pain during intercourse, and their skin becomes so fragile it bruises and rips with just like minimal friction.
Minimal friction, just from daily movement.
Exactly. Visually, our sources describe the lesions as presenting with ivory white or porcelain white patches.
And in women, these patches frequently coalesce into a really distinct figure of 8 pattern, right? Encircling the vulva and the anus.
Yes, that figure of 8 is a classic sign. The texture of the skin also undergoes this radical transformation. The clinical term they often use is that it begins to look like cigarette paper or crinkled parchment.
So it just loses all of its natural elasticity.
All of its suppleness, yeah. And if that inflammation is left unchecked, that thinning progresses to devastating anatomical distortion.
Anatomical distortion, you mean like physical changes to the body?
I mean irreversible structural scarring. The chronic inflammation literally melts away and fuses normal anatomy together.
Wait, what?
Yeah. In women, this manifests as the resorption of the labia minora, where the tissue simply flattens and disappears.
Oh my God. The sources also detail clitoral phimosis, where the scarring actually buries the clitoris beneath fused tissue.
Yes, it gets completely buried.
And introital stenosis, which is a severe narrowing of the vaginal opening that can make any form of penetration or intercourse physically impossible.
It's devastating for the patients.
Wait, I need to stop you there, actually. I want to push back on something because it feels like a glaring contradiction to me.
Okay, sure.
You're describing a disease that turns the skin paper-thin-like, fragile enough to tear like wet tissue paper, but you are simultaneously saying it causes thick, unyielding, fused scar tissue.
Right, I see what you mean.
How can the tissue be both at the same time? That feels totally contradictory.
Yeah.
And honestly, if the symptoms are this physically destructive and visually distinct, why on earth do doctors miss this?
That paradox is exactly why it gets missed.
Really?
Yeah, the destruction you just described, the fused tissue, the thick scarring, that is the end stage of the disease. In the early stages, before that permanent, dense scarring sets in, the presentation is incredibly deceptive.
Because it just looks thin and irritated.
Exactly. The initial itching, the redness, and the superficial skin changes closely mimic incredibly common benign conditions. A patient might sit in the clinic and be told they just have, a stubborn yeast infection.
Or like contact dermatitis from a new laundry detergent.
Right. Or just a standard case of eczema.
So they get sent home with over-the-counter anti-itch creams or basic antifungals that do, well, absolutely nothing to stop the underlying mechanism.
Leaving the disease to quietly progress in the background. And in pediatric cases, this deceptive presentation is even more tragic.
Oh, because of the bruising.
Yes. Because the skin loses its structural integrity early on, even just the friction from walking or wiping can cause ecchymosis bruising and tearing.
Which is horrifying for a child.
It is. When a prepubertal girl presents to a doctor with unexplained genital bruising and tearing, the immediate mandated clinical suspicion is almost always sexual abuse.
Wow. And while abuse and lichen sclerosus can certainly coexist, the disease itself is just frequently misidentified as trauma,
Constantly misidentified.
which is compounded by something in the literature called the Koebner phenomenon, right?
Yes, the Koebner phenomena.
This is where physical trauma or friction to the skin actually induces new lichen sclerosus lesions to form right at the site of the injury.
It's a devastating feedback loop. The
Yeah.
very act of scratching that intractable, maddening itch physically causes the disease to spread and worsen.
That is brutal.
It really is. So clinicians cannot simply rely on a visual exam, especially in those early, confusing stages. They have to look closer.
They need a biopsy.
Exactly. They have to take a tissue biopsy and analyze the architectural changes under a microscope.
Which takes us from the macroscopic clinic down to the microscopic battlefield. Let's get into the pathology.
Let's do it.
When a pathologist puts a tissue sample of late-stage established lichen sclerosus under the lens, the sources describe this very classic definitive presentation. It's often referred to as a red, white, and blue pattern.
Which is a great way to remember it.
Let's break that down, starting with the red.
So the red refers to hyperkeratosis, and this is actually part of that paradox you pointed out earlier.
About the thin skin versus thick scars.
Exactly. Even though the living, deeper layers of the epidermis are atrophying and thinning out, the very top layer of dead skin cells, the keratin, hyperaccumulates.
Oh, so it just piles up.
Right. It piles up on the surface and stains a deep pink or red under the pathologist's dyes.
Got it. And then below that red layer is the white, the dermal sclerosus.
This is the concrete. It appears as a pale, homogenized, almost glassy band of scarred collagens sitting right beneath the epidermis.
Meaning the healthy, flexible dermal tissue is just gone.
Entirely replaced by dense scar tissue.
Wow. And finally, the blue is a dense, band-like infiltrate of lymphocytes. Basically an army of blue-staining immune cells sitting just below that white scar band.
Essentially driving all the destruction, yes.
So you have red at the top, a thick white scar band in the middle, and a blue immune army at the bottom. I mean, that seems like an incredibly straightforward diagnosis for a pathologist.
In late-stage disease, it absolutely is straightforward. The critical challenge arises when a patient gets biopsied early on.
Before the scars form.
Exactly. In what pathologists call non-sclerotic lichen sclerosus, that classic white band of dermal scarring hasn't formed yet. The foundation hasn't completely turned to concrete.
So if a pathologist is only scanning the slide for that bright white band to make their diagnosis, they're going to miss it,
They will look right past the early disease.
leaving the patient to continue suffering through more yeast infection misdiagnoses.
Precisely. To catch it early, the focus has to shift entirely. The pathologist has to look at the exact junction point between the layers, the basement membrane.
By basement membrane.
Yes. This is the crucial microscopic layer that glues the epidermis, the top layer of skin, to the dermis below it.
Okay, so what do they look for there, if not the white scar?
In early LS, instead of a thick white scar, pathologists look for interface dermatitis, which is a specific pattern of inflammation right along that junction.
Okay.
They also look for vacuolar degeneration, where the basal cells at the bottom of the epidermis start developing these empty, damaged spaces. It almost looks like they're bubbling.
Bubbling cells. That can't be good.
It's not. But most importantly, they look for basement membrane thickening.
All right. One of our sources, a really detailed study on juvenile vulvar lichen sclerosus, noted that this specific thickening was present in 8% of the juvenile cases.
It's a huge clue.
It serves as this incredibly vital diagnostic breadcrumb before the permanent scarring happens. So, going back to our building foundation analogy,
Yeah.
is the basement membrane, basically, like the structural mortar between the bricks of the top floor and the bottom floor. And in lichen sclerosus, the immune system is packing in so much extra defective mortar that the wall distorts and thickens.
What's fascinating here is how well that holds up on a cellular level. The basement membrane is the mortar. It is the mechanical anchor holding the skin together.
So the thickening is the mortar failing.
Yes, the thickening you see under the microscope isn't a sign that the mortar is getting stronger or reinforcing the wall. It is a sign of severe damage and chaotic, abnormal tissue remodeling.
Meaning the structural integrity is failing and the
Right.
tissue is just swelling as a result of all that damage.
Exactly. The immune cells are launching an attack, and the local tissue is desperately trying to repair the damage. But the repair process itself is deeply flawed.
Because it's under attack while trying to rebuild.
Right. The tiny blood vessels sitting just underneath that basement membrane begin to dilate. The delicate structural proteins that make up the membrane get altered and tangled.
The foundation of the skin is fundamentally compromised before a single scar has even formed.
Perfectly said.
Okay, so we know what is happening. The basement membrane, the mortar, is swelling, thickening, and failing. The obvious question now is why?
Why is the body doing this?
Yeah. What is triggering this highly specific autoimmune sabotage?
The mechanism comes down to the specific proteins that constitute that basement membrane. Current research highlights that the basement membrane isn't just collateral damage, it is the primary initial target of the inflammation in lichen sclerosus.
So it's ground zero for the entire disease process.
It is ground zero. Scientists have actually isolated circulating IgG autoantibodies in the blood of these patients.
And just to clarify, autoantibodies are immune system proteins that have essentially suffered an identification error, right?
Yes, they mistakenly tag the body's own healthy tissue as a foreign invader.
Yeah.
In the case of LS, these autoantibodies are hunting down one very specific structural protein located inside the basement membrane called extracellular matrix protein 1.
Or ECM1.
ECM1, exactly.
And looking at the prevalence of this in the sources, I mean, it is staggering. These anti-ECM1 antibodies are found in 60 to 80% of women presenting with vulvar lichen sclerosus.
Some studies even pinpoint the correlation right at 75%.
That's massive. The body's immune system is actively and specifically launching a targeted strike on its own structural glue.
And when those autoantibodies lock onto the ECM1 protein, it triggers a catastrophic cascade of localized destruction. The binding of the antibodies leads to an intense spike in the activity of an enzyme called MMP9 collagenase.
Collagenase, meaning an enzyme designed to break down collagen.
Think of it as a microscopic chemical wrecking ball. Yeah, the body starts releasing this wrecking ball directly into the basement membrane, physically degrading the mortar.
And the immune system's involvement just escalates from there. The sources detail a massive influx of T cells, which is that blue band we discussed in the late-stage pathology.
The Blue Army.
Right. The T cells infiltrate the dermis and begin orchestrating what they call a cytokine storm.
Yes. They release potent inflammatory chemical messengers, specifically interleukin-4 and TGF-beta. These cytokines essentially act as panic signals.
Screaming at the local fibroblasts.
Screaming at them. And fibroblasts are the cellular workhorses responsible for building and maintaining connective tissue.
So under normal circumstances, those fibroblasts would maintain a healthy, flexible dermis, but under the influence of these panic signals from the T cells.
They go into overdrive. They begin overproducing a highly altered, abnormal type of collagen.
That panic building is the direct cause of the hyalinization, right? That glassy, thickened appearance of the tissue under the microscope.
That's it. And ultimately, it's what forms that thick, white band of permanent dermal scarring.
Okay, here's where it gets really interesting. Connecting the dots between this deep cellular immunology and the terrible reality the patient is facing on the surface.
Let's connect them.
If the body is actively attacking its own ECM1 structural glue, hitting the basement membrane with wrecking ball enzymes, and then replacing healthy tissue with defective collagen, that completely explains the macroscopic nightmare we talked about earlier.
Yes. The autoimmune attack is literally degrading the mechanical integrity of the skin from the inside out,
The epidermis is just no longer safely anchored to the dermis below.
which means the slightest amount of everyday friction, like wearing tight clothing, wiping with toilet paper, sexual intercourse, it causes the unanchored tissue to physically shear, split, and bleed.
So the cigarette paper wrinkling isn't just a surface texture issue. It is happening because the skin has completely lost its deep structural support and natural elasticity.
The microscopic protein battle is directly creating the bruising, the tearing, and the agony.
It is a perfect, tragic chain of cause and effect.
It really is, and understanding that mechanism brings us directly back to the clinic. We know the basement membrane is thickening because of this anti-ECM1 attack. We know it precedes the permanent scarring.
So what does this all mean for the patient? Like, why does identifying this specific thickening matter so much to the actual treatment of the person sitting on the exam table?
It all comes back to the misdiagnoses. Early non-sclerotic lichen sclerosus is incredibly easy to confuse with other inflammatory skin conditions.
Right, the yeast infections and eczema.
Yes, but not just visually in the clinic. Even under a microscope, if the pathologist doesn't know exactly what to look for, it's tricky. The sources point out that the biggest mimic in dermatopathology is a condition called lichen planus.
Lichen planus.
Yeah. Both conditions present with intense itching. Both cause significant pain. Both feature an aggressive lymphocyte infiltrate that blue army of immune cells attacking the skin.
So if a pathologist is looking at an early biopsy that lacks the classic white scar band, telling those two apart can be incredibly difficult.
This is where the basement membrane steps in as the ultimate tiebreaker.
Ah.
The mechanisms of dispersion in the two diseases are fundamentally different. In lichen planus, the autoimmune attack is so aggressive against the basal cells that it actually destroys the basement membrane.
Destroys it completely.
Yes,
And-
under the microscope, you see a total loss of the membrane, or at the very least, a distinct lack of thickening. You also see a classic feature pathologists call sawtooth ridges.
Meaning the downward projections of the epidermis look jagged and sharp, like the teeth of a saw?
Exactly. But in lichen sclerosus, the architecture behaves in the exact opposite manner.
Instead of sawtooth ridges, you see epidermal atrophy, so a complete flattening out of those ridges.
Right. And crucially, instead of the basement membrane disappearing, you see that definitive thickening. The mortar swells as it fails.
Spotting that swollen, thickened mortar is the smoking gun.
It is.
It is the definitive proof required to stop guessing. Once that thickening is confirmed, the clinician can immediately pivot away from those useless over-the-counter yeast creams.
And prescribe the gold standard first-line treatment, ultra-potent topical corticosteroids like clobetasol.
And the urgency of starting those ultra-potent steroids just cannot be overstated, right?
No, it can't. When applied correctly and maintained consistently over time, these medications don't just soothe the surface itch, they penetrate the tissue and directly suppress those aggressive T cells.
They shut down the cytokine storm.
Exactly. If the T cells can't release interleukin-4 and TGF-beta, the fibroblasts stop panic building the defective collagen. The immune system is physically blocked from attacking the basement membrane.
Which means you halt the architectural scarring before it can permanently ruin the patient's anatomy.
You prevent the labial resorption, you prevent the clitoral phimosis and the introital stenosis.
You preserve their physical anatomy, their sexual function, and honestly, their psychological well-being.
But the sources also highlight another, even more critical reason for early aggressive intervention.
The cancer risk.
Yes. Beyond the scarring, vulvar lichen sclerosus carries a 4% to 6.7% risk of transforming into squamous cell carcinoma.
Which is a highly dangerous form of vulvar cancer.
It is. If we connect this to the bigger picture, recognizing basement membrane thickening is far from a purely academic exercise for a pathologist sitting in a lab.
It's life-saving.
It is the definitive trigger that initiates disease-modifying treatment. Spotting that thickened line under a microscope saves patients from years of painful, agonizing misdiagnosis. It halts the destruction of their physical anatomy, and it critically mitigates a very real, life-threatening risk of malignancy.
It's really a profound journey we've mapped out today. We started with a macroscopic nightmare, Patients dealing with life-altering itching, severe tearing, and irreversible scarring that disrupts their sleep, their relationships, and their mental health.
A truly awful daily reality.
And we were able to trace all of that massive physical destruction all the way down to a microscopic protein identification error at the basement membrane.
The ECM1 protein.
The body's own immune system treating its structural glue like an invading enemy, literally turning the foundation of the skin to rubble. I mean, it completely validates the necessity of looking closer, of demanding a biopsy, and just not settling for the first easiest answer when symptoms refuse to resolve.
The pathology always tells the true story, provided we know how to read the subtle signs. And, if we connect this to the broader frontier of dermatological research, there is one final fascinating detail in our sources regarding where treatment might head in the future.
Oh, I love looking at it. What is it?
We know the basement membrane is ground zero for this inflammation. Well, the literature notes that the progression of lichen sclerosus and the potential malignant transformation into squamous cell carcinoma may actually be driven by oxidative stress.
Oxidative stress. So the chronic, relentless inflammation is generating reactive oxygen species like free radicals that wreak havoc on a cellular level and actively damage the DNA of the surrounding tissue.
Exactly. The immune attack doesn't just destroy the physical structure. The resulting oxidative stress creates an environment ripe for cellular mutation.
Wow.
Which raises a really compelling question for the future of medicine.
Okay, let's hear it.
If we know the basement membrane is the focal point of this oxidative stress and DNA damage, could future therapies move beyond simply applying ultra-potent steroids to blindly suppress the immune system?
Oh, I see where you're going with this.
Could we eventually see highly targeted antioxidant therapies delivered directly to the basement membrane zone? Therapy specifically designed not just to stop the itch or suppress the T cells, but to actively neutralize the free radicals, heal the damaged DNA, and definitively reverse the risk of cancer.
Moving from merely managing the damage to actively repairing the foundation.
Exactly, something for you to ponder.
Actively repairing the foundation before the walls ever have a chance to crack. That is an incredible thought to end on. Thank you to everyone for joining us on this deep dive. Keep questioning and always keep looking closer.